everyone. I'm Dr. Gurpreet. I'm from Ludhiana. I'm a pediatric neurologist in Ludhiana, Punjab. So today we have a an interesting case discussion. It's a festival time, and most of the people were busy either in festival or the PGs were busy in their thesis. So we were lucky to find Dr. Arun YB, who prepared a case, and Dr. Raju, who will be moderating. So to introduce Dr. Raju, he's DM Pediatric Neurology from AIMS and presently Professor and Head, Indira Gandhi Institute of Child Health at Bangalore. So I hand over to Dr. Raju, who will introduce Dr. Arun, who is his pediatric neurology fellow, and he will be presenting case, and we will be having discussion in between also. And if you have any questions, you can type in chat box or Q&A section, and we can have discussion in between also. So Dr. Raju, please, you can start.
Yeah. Thanks, Dr. Gurpreet. So today we'll be presenting a rare case. This is presented by Dr. Arun. He is currently working as a pediatric neurology fellow at Indira Gandhi Institute of Child Health, Bangalore. So he'll be going to present now case. Over to Dr. Arun.
Thank you, sir. I'll share my screen now. Sir, is the screen visible?
Yes.
Yes, sir. Audio is clear, sir?
Yes, yes.
Okay, sir. Good evening, everyone. I am presenting a case of a rare cause of recurrent encephalopathy with who presented like a leukodystrophy. This case is being presented from Indira Gandhi Institute of Child Health from Bangalore. Coming to the demographic details of my patient, baby named PRB, aged 1 year, female. Informant was mother, was a reliable informant. They are from Assam, Karnataka, and we have taken permission to display the clinical picture and video from the parents. She presented to us with chief complaints of fever with rash 40 days back. And she also had right-sided weakness along with associated lethargy since the last 5 days. So these are the chief complaint: fever with rash and right-sided weakness with lethargy. Coming to the detailed history of presenting illness, fever with rash was 40 days back. The fever was moderate to high-grade fever, intermittent type, which used to resolve with taking medications. The fever was associated with pleomorphic rash, initially vesicular, maculopapular with vesicles, which started on day 2 of fever. It started initially at face, then followed by neck and trunk. Progressively, it involved limbs also. This fever lasted for 2 days, and the rashes resolved over a period of 10 days with scarring. At the same time, one more cousin in the household had the similar complaint of fever with rash. So, and there was also other history of significant history of child was dull during that febrile period with reduced playfulness, poor oral intake. She used to prefer to stay in bed for those 2 days of fever with rash. This was the history regarding fever with rash. Then when she presented to us, she actually presented with main complaint of right-sided weakness since the last 5 days before admitting to our hospital, with prior history of fever with rash 1 month back. Coming to the right-sided weakness description, she had weakness of right upper and lower limb since the last 5 days. The weakness was insidious in onset, and it was gradually progressive, involving more of right upper limb than right lower limb. And the severity of the weakness was she was only able to move the limb sideways. She was not able to lift limbs against the gravity. This weakness of the right-sided limb was also associated with truncal weakness, causing inability to sit up. However, she was able to roll over. There was no associated weakness in the other limbs. There was no facial deviation. There was no history of trauma preceding onset of the weakness. And one more history is lethargy since the last 5 days prior to admitting in our hospital. Along with weakness, she also had a history of lethargy in the form of excessive sleepiness with intermittent episodes of irritability. She used to prefer to stay in bed with poor feed intake and also had reduced interaction, reduced playfulness. And but this lethargy was not associated with vomiting. There was no associated history of seizures. For this complaint, she was admitted in our hospital. She was admitted twice in our hospital. So she was admitted for about 1 week. That time we were given supportive care and she was evaluated for the etiology of the same fever with rash followed by weakness and lethargy. And she got discharged after 1 week of admission from our hospital. Continuation of history of presenting illness. She was discharged after 1 week and gradual recovery was noted over a period of weeks. She regained ability to sit over the next 2 weeks and was able to lift her arm, lift her right upper and lower limb, which she was not used to do during the initial presentation to us. However, she persisted to have mild right-sided weakness. She never reached the previous power. And again, she was admitted to our hospital. This is a history of presenting illness in second admission. She was admitted after 3 weeks of discharge from our hospital. At the discharge from our hospital, she was recovering in the form of she was able to move her limbs against gravity, and over a period of 2 weeks, her power was improving. After 3 weeks of discharge, she developed intercurrent febrile illness, which was fever with cold and cough for 2 days duration. This episode of fever was also associated with lethargy, poor feeding from day 2 of fever. She was readmitted to our hospital 3 weeks after the discharge. That is, this was second admission. This time she presented with history of fever, lethargy, poor feeding, but the severity of lethargy and altered sensorium was more. So I'll describe about altered sensorium in second admission. In second admission, when she presented to us, she was drowsy. There was history of drowsiness, irritability, and excessive crying and reduced feeding. There was also associated hurried breathing with mild chest retractions, but there was no history of cough. Poor feeding was noticed in the form of she was having suppressed suck cycle along with associated forehead sweating during the feeding. She also had cold peripheries and reduced urination. Hence, with history of fever with altered sensorium and hurried breathing with cold peripheries, she was admitted to ICU. Course in ICU, she was in shock, requiring inotropic support and mechanical ventilation. She succumbed in spite of the best effort on fourth day of ICU stay. This is history of presenting illness. Past history, at 4 months of life, there was history of fever with cold, and during this time, child was dull with reduced feeding for 3 days, treated on OPD basis only. There was no weakness or admission necessity for admission that time. This was at 4 months of life. No significant hospitalization in past history. Coming to the birth history, mother had gestational diabetes. She received insulin from 7 months of gestation. No other comorbidities. Otherwise, antenatal history was uneventful. Birth history, the child was born at term. LSCS born. Indication was cephalopelvic disproportion. Birth weight 3.5 kg. Cried immediately after birth. Child was active and feeding well on day 1. No history of NICU admission. Coming to the developmental history, the first table indicates milestones prior to the febrile illness, that is prior to the first admission to our hospital. The gross motor, she attained neck holding by 5 months, rollover by 6 months. She was able to sit without support at 8 months. She was able to crawl at 11 months. Fine motor, bidextrous reach at 6 months, unidextrous reach at 8 months, able to transfer object at 9 months. Language, turn to sound by 3 months, cooing by 6 months, monosyllable by 9 months, and bisyllable by 11 months. Social smile by 3 months, recognizes mother by 4 months, stranger anxiety by 8 months. Impression, motor milestones are affected predominantly than social and language milestones. Child was only able to crawl at 11 months of gestation, 11 months of age, but she was able to speak in bisyllable, and stranger anxiety was present. After the first admission, that is at the first admission, when she presented to us with history of right-sided weakness with history of altered sensory irritability, that time she was noticed to have lost milestones, some of the milestones. In gross motor, she had only neck holding and ability to roll over was preserved, but she was not able to sit. She used to reach out for object predominantly by using the left hand, and cooing was preserved. She was recognizing mother. Again, all the milestones are regressed after following a febrile episode, following a febrile illness and right-sided weakness with altered sensory. This is a graph depicting deterioration of milestones with mild delay prior. Mild delay was there prior to the admission. With after this first admission, she had lost some of the milestones. Again, recovered over a period of 3 weeks, followed by regression in the second admission, and child succumbed to death. Coming to the family history, the child is only born child to secondary consanguineous marriage. There was no prior history of abortions, no similar history in any of the family members, no history of developmental delay or similar complaints in any of the family members. Coming to the summary after the history, child initially 40 days back had history of fever with vesicular rash, most likely varicella, because of history of similar illness in one of the cousin. However, she recovered without any problem. But during that time, the child also was noticed to have reduced feeding and playfulness during that febrile period. During the febrile period of fever with rash, along with significant past history of at 4 months of age, child had fever with reduced activity. And child was admitted after 40 days of the fever with rash, that is approximately after 1 month of resolution of rashes with history of right-sided weakness and inability to sit. This was our first admission. That time, child also was noticed to have lethargy and irritability along with weakness. She was admitted to our hospital, was treated with supportive care only, and etiological evaluation was done with the provisional diagnosis of post-varicella vasculitis bar stroke, post-infective demyelination, and possibility of metabolic cause. After 1 week of admission, the child started recovering. So she got discharged. Over a period of 3 weeks, child was recovering with improvement in the power in the right-sided limbs. But again, she developed in the recovery in the form of she was able to sit after the discharge and was also able to lift right side of the limbs. Then following 3 weeks of discharge, the child developed intercurrent febrile illness with cough and cold. That time, child was also noticed to have lethargy, poor feeding, with cold peripheries and hurried breathing. For this complaint, she was admitted within 3 weeks of discharge with history of encephalopathy and shock. She was admitted in ICU. In ICU, she had clinical deterioration, worsening of the sensorium with poor feeding, breathing difficulty, and shock. Expired after 4 days of ICU care.
Arun, what is the age of the child? Many people have joined late. In your summary, you should tell the age of the child also.
Yes, sir. 1 year child, sir. When she presented to us, she was 1 year, sir. First admission. First admission, her age was 1 year. She presented with fever with rash and reduced feeding 40 days back. Later, she was admitted with history of right-sided weakness, lethargy, and irritability. And she gradually recovered over a period of weeks. Then again developed intercurrent febrile illness with URTI. This time she had worsening, requiring ICU stay along with shock.
Okay, fine.
The differential diagnosis considered at this stage were post-chickenpox vasculopathy or vasculitis causing stroke or stroke-like episodes, demyelinating disorder, post-viral or neurometabolic disease with history of febrile illness with altered sensorium and loss of milestones. These were the differential diagnosis at the end of history we have kept, sir. Coming to the points in favor and against of our provisional diagnosis. Points in favor was for chickenpox vasculopathy or vasculitis was preceding history of chickenpox 40 days prior to the onset of weakness and altered sensorium. Points against was usually the chickenpox vasculopathy or vasculitis, which presents like stroke, will be monophasic illness. This child had 2 episodes of fever with regression of milestones, fever with altered sensorium. And one more point against chickenpox vasculopathy or vasculitis is the weakness was not maximal at the onset, sir. The weakness was gradually progressive over 2 to 3 days, and it was noticed insidiously weakness. And there is history of recurrent encephalopathy with fever, which is against chickenpox because it is usually monophasic.
So in the history at this stage, are you able to tell this is a stroke or stroke-like episode? Any points in general? Whether do you label as a stroke or is a stroke-like episode? Any points in general, not in the specific to etiology?
Yes, sir.
So on history-wise, you were able to differentiate a stroke or a stroke-like episode?
So history-wise, it appears like stroke-like episode because the weakness was insidious in onset and gradually progressed. The weakness was not maximal at the onset, and she was able to move her limb sideways. So the power was preserved. So it looks like stroke-like episodes.
Now, what are the other points that tells it is a stroke-like episodes in this child that are present? The degree of encephalopathy.
Yes, sir. Degree of encephalopathy was
involvement of cranial nerves.
There was no deviation of.
Is it a vascular distribution or non-vascular distribution?
It was non-vascular distribution, sir, according to history.
So it is more in favor of stroke or stroke-like episodes?
Stroke-like episodes. One more possibility, one more differential diagnosis was post-viral demyelination. The points in favor were the onset was preceded by infectious etiology, post-infectious, and the limb weakness was asymmetric, which is usually seen in demyelinating disorder. This child had right-sided weakness. Then also there was history of altered sensorium, which is usually seen in demyelinating disorders like ADEM. Child also presented to us like a stroke-like presentation, stroke-like episode, that is demyelination is possibility, and the weakness was progressive, not maximal at the onset. The points against...
What is the meaning of progressive weakness? Onset is insidious, but progression is not progressive weakness.
Okay. Points against demyelination were history of recurrent encephalopathy during febrile illness at 4 months of age, along with fever with rash and one more episode of fever with encephalopathy, which cannot be explained by demyelination. And there was baseline mild developmental delay in all the domains, motor more than cognitions, motor more than social and language, which is against demyelination. One more differential was neurometabolic cause. Points in favor were consanguineous parentage, second degree consanguineous marriage, and there was baseline developmental delay, history of recurrent encephalopathy and regression of milestones following febrile illness was in favor of neurometabolic disease. However, in history, we didn't get history suggestive of child not gaining adequate weight. There was no history of failure to thrive, and no other history like recurrent vomiting, abnormal odor. This history.
No, at this level, you were able to tell any specific neurometabolic disorder? Which neurometabolic disorder you were suspecting?
Mitochondrial
one
disorder.
Side weakness.
Yes, sir.
Huh? One side weakness is in fever.
Melas is a possibility, sir. Melas, but there was no stroke. Melas, mitochondrial disorders.
What is the age of presentation usually Melas? Which mitochondrial disorder usually presents at 1 year of age?
Leaks disease, sir. But they won't present with stroke-like episode.
Which one they will not present? Leaks disease.
Leaks disease.
So which are the other neurometabolic disorder you think of?
Hyperhomocystinemia.
Okay. Any other cause of metabolic strokes? What are the other causes of metabolic stroke? The child presented in stroke-like episode. What are the other metabolic reasons causing stroke-like episode with encephalopathy? Other than mitochondrial.
Organic aciduria, sir. Which one?
Okay. What else? Other like urea-cycle disorder.
Urea-cycle disorder. Yes, sir. Urea-cycle disorder, organic aciduria, mitochondria.
Okay.
These were the differential diagnosis following history, sir. Proceeding to the examination, this is divided into examination at first admission and second admission. At first admission, when child presented with history of weakness, the vitals were stable, and anthropometry weight was 7.5 kg between 0 to -2, length 72 centimeters, 0 to -2, and head circumference was also normal, sir, -1 to -2 z-score, and weight for length was between -1 to -2 z-score. There was impression is there was no failure to thrive, no microcephaly prior to this prior to admission. Coming to the systemic examination during first admission, higher mental function test, child was dull, irritable, with inconsolable crying during admission. Clinical videos I will be showing later. Cranial nerve examination, mild facial asymmetry in the form of loss of nasolabial fold on the right side was noted. And other cranial nerves were intact, sir. There was no deficits in other cranial nerves. Coming to the motor system examination, bulk was symmetrical and normal. Tone is increased in all the limbs, more on the right side. And power in the limbs was in right upper limb, it was 2 - by 5, lower limb was 2 + by 5. In the left side, it was more than 3 by 5, sir. And reflexes were brisk. Plantar was extensor. There was no cerebellar signs, no signs of meningeal irritation. Spine and cranium was normal. This was the clinical photograph of the child during the first admission. In this, we can make out child is moving our left upper limb, but the left upper limb, but the right upper limb she has kept in the same posture. And child is also having irritability and altered sensorium, which we can make out in the appearance. Looks drowsy and irritable. And other system examination at first admission was normal. Coming to the examination in the second time, when child presented with history of fever, cough and cold of 2 days duration with cold peripheries, altered sensorium, arid breathing. This time, child was noticed to have alterate of tachycardia with tachypnea with CFT more than 3 seconds. Cold clammy peripheries was there. Child was in shock at admission. And in CNS examination, child was lethargic, unresponsive. GCS was 7/15. Reflexes were brisk. And CVS examination, tachycardia was there with systolic murmur. RS silent tachypnea, only basal crepitation side, minimal intercostal retractions. Per abdomen, abdomen was distended with hepatomegaly 4 cm below the right costal margin. Span was 11 cm, soft in consistency. This time child presented with compensated shock with tachycardia and signs of cardiac failure, congestive cardiac failure in the form of hepatomegaly, tachypnea, and tachycardia, along with associated drowsiness, lethargy. These are the videos I'll be playing. The first video is done on day 1 of first admission. In this video, we can make out child is irritable, drowsy with reduced movement on the right side. And child was noticed to be having not able to sit, like she was not able to sit at first admission. She presented to us with right-sided weakness. Here the right lower limb is turned outside. And she is not able to sit and not able to lift arms. One more video. This is first admission during the hospital stay when she was recovering. This time her activity was improved, not in altered sensorium. And the movement in the left upper limb looks normal, and she has flexed posture at the left lower limb, but right lower limb she has lost the tone, and she is not moving the right upper limb. So power in the right upper limb looks like 2/5, no, like 1/5. The child was moving the left upper and lower limb with the reduced power in the right side. This was during the recovery. In the first hospital admission. This video after discharge from the hospital when she was in home. In this video, we can make out she preferably uses left arm to hold the object, and she puts left leg to move that walker. Right hemiparesis persisting even after the recovery.
Next.
Sir, slide. Sir, slide got added, sir. I will share again.
No problem. You can restart.
Sir, can you see the screen? Sir, is the screen visible, sir?
Yeah.
Yes, sir. After the history and examination, our provisional diagnosis was a case of global developmental delay with quadriparesis, right more than left, with recurrent encephalopathy, with loss of milestones following episodes of febrile illness, and presented with cardiac failure, secondary to suspected metabolic etiology.
So at this stage, how we were ruled out other causes?
Sir, the differentials which we kept after history were post-varicella stroke and demyelinating disorder, sir.
After the exam, can you, any points against after the examination, those differential diagnosis, what you were kept earlier?
This child presented in shock with cardiac failure, which is not explained by other etiologies, sir. And
no, baby should have been developed sepsis following some infection. Yeah,
yes,
that may be a possibility. Maybe complication treatment if they are given steroid or something. So child should have been developed sepsis and shock.
With the examination, I was able to rule out so stroke was possible because mild facial asymmetry was mild loss of nasolabial fold was noticed on the right side. Stroke was not able to rule out, but with history of recurrent encephalopathy and loss of milestones with cardiac failure, possibility of metabolic etiology was kept.
So at the end of examination, more of metabolic is more positive rather than post-infectious vasculopathy and demyelination.
Yes, sir.
Okay.
Coming to the investigation, this was the investigation done at first admission when the child presented with weakness. HB was 12.4. The complete hemogram looks normal, sir, with the peripheral smear showing dimorphic picture with mild leukocytosis with hypersegmented neutrophils. Platelets were adequate. LFT was normal. Calcium, phosphorus, and RFT serum electrolytes were normal. ABG at the first admission, pH was 7.336, mild acidosis with bicarbonate 18.6. Lactate at first admission was 34, ammonia was 21. When child presented second time in deterioration with shock, that time pH was 7.074, bicarb was 5.1, lactate was elevated, ammonia was also increased. Even initially at the first admission, lactate was slightly elevated and mild metabolic acidosis was noted. Vitamin B12 and homocysteine done as a part of stroke workup as well as peripheral smear showing hypersegmented neutrophil was normal. And CSF analysis was done to rule out demyelinating disorder. It showed 2 cells lymphocytes, glucose and protein normal, and oligoclonal bands and serum NMO emoji was negative. Coming to the neuroimaging, which was done at first admission when child presented with history of weakness with irritability, lethargy that time also. This is the MRI axial section showing diffusion hyperintense signal in the diffusion weighted image involving symmetrical white matter, both periventricular and subcortical, predominantly frontal. It is seen predominantly in the frontal region. However, the posterior part is also involved. One more MRI showing a similar hyperintense signal in the diffusion weighted images involving bilateral symmetrical frontal white matter. And corresponding ADC shows restriction in the corresponding areas of hyperintensities of the diffusion weighted restriction, suggestive of possibilities of cytotoxic edema. Can make out restriction ADC, low intense signal in the ADC. And this was a T1 weighted image showing hypointensities symmetrical involving predominantly again frontal white matter. Coming to the T2 weightage image, this again showed symmetrical hyperintense signal involving predominant frontal white matter along with posterior white matter also, but no changes in the basal ganglia was noticed. Same T2 weighted image in coronal section showing white matter hyperintensities, hyperintense signals. This was a T2 flare image showing mild hyperintensities in the bilateral frontal region, white matter. After the diagnosis which were kept after looking at the MRI with the findings of bilateral symmetrical frontal white matter intensity signal changes, we have kept the possible diagnosis based on MRI as 3 causes: primary mitochondrial disorder, Alexander disorder, and one more is viral encephalitis. So coming to the points Primary mitochondrial disorder usually presents as white matter signal intensity changes with pattern similar to that of the leukodystrophy that can be seen in several primary mitochondrial disorders like MELAS and MERFs and mitochondrial complex
MELAS and
deficiencies.
MERF, they will not be bilateral symmetrical.
Yes, sir. It is mostly asymmetrical and posterior part of the white matter will be involved. And in mitochondrial complex deficiencies, one of the example is succinate dehydrogenase, that is part of complex 2, where they'll present with bilateral symmetrical white matter changes involving all, sir, like both posterior and anterior white matter. This is complex 2 deficiency, where the white matter changes similar to that of the leukodystrophy is seen predominantly. Along with that, I think there will be associated cerebellar atrophy. And one more possibility is Kearns-Sayre syndrome, where again frontal predominance is not seen.
So with clinical correlation, which is more likely in this out of 3?
Mitochondrial disorders or mitochondrial complex deficiencies. Usually they present with leukodystrophy like picture, like leukoencephalopathy like picture. Some of the mitochondrial complex deficiencies can present with leukoencephalopathy like picture.
So why it is not MELAS, MERF and cases?
The symmetrical involvement, predominant involvement of the frontal.
Cases also symmetrical will be there.
Yes, sir.
How to differentiate cases? Usually cases onset is very late. Usually they will not.
Yes, sir. Clinically onset will be less. Onset will be less visual complaints.
Ophthalmoplegia.
Ophthalmoplegia. Yes.
Subcortical fibers can be involved.
Subcortical fibers involved in Kearns-Sayre.
What are the other metabolic condition possible? Somebody is asking, is it possibility of urecycle disorder based on MRI?
In urea cycle disorders, usually periventricular white matter and basal ganglia changes are seen.
No, in urea cycle, brainstem
and white
periventricular. Also not common in urea. It is more common in mitochondrial disorder. So based on MRI,
yes, sir.
So is it urea cycle disorder possible or not possible? So usually urecycle disorder in general, they will involve temporal lobes. They can be unilateral, asymmetrical, bilateral, asymmetrical or unilateral. Usually temporal lobe involvement and sometimes white matter also involved. So it will not be very so much symmetrical. Maybe cannot totally rule out.
Yes, sir.
Can it be L2-hydroxyglutaric aciduria as somebody has ordered?
Yeah. Is it L2-glutaric aciduria?
L2-glutaric aciduria.
Is it possible you are aware what is L2-glutaric?
Yes, sir. Usually brainstem involvement will be there more predominantly, and large jet clinical features will be.
Yeah, clinically large jet, they are insidious onset, and usually subcortical U fibers are predominantly involved. So, and it is diffusion restriction may not be so obvious like what is seen and with acute onset features. Okay. Next.
One more differential based on MRI for predominant frontal white matter involvement. We considered one more as Alexander disease, but history was not suggestive. This is DD based on MRI, sir. Diffuse white matter hyperintensities are seen predominantly involving the frontal white matter in T2-weighted images. There is a criteria for Alexander disease given by Vandernapp, which requires 4 out of 5 criteria to diagnose based on MRI.
You can tell what are the points not in favor of Alexander in general. Based on MRI,
yes, sir.
Possible or not possible? What are the
not
points
possible, sir. Points against is points against based on MRI. There was no periventricular rim, sir. It is one of the required criteria: presence of periventricular rim on T2-weighted image, and basal ganglia involvement was not there in our case. Basal ganglia and thalamus was paired. And midbrain and medulla was also spared. And contrast we have not done. So first point was fitting, but next 3 points were not fitting, sir.
Yeah, okay. Maybe diffusion restriction may be there, but not so obvious like in our case, and presentation is too acute.
Yes,
and
sir.
what about vanishing CSCH, childhood attacks with central CNS hypomyelination? Is it possible based on MRI? They will also present clinically like acute deterioration following febrile illness or any trauma. CSCH is possible, vanishing white matter disease.
Involves all white matter, sir, like.
Here also involvement of subcortical and periventricular white matter involvement is there. What are the points that tells it is not vanishing white matter disease?
Usually the intensity will be similar to that of a CSF.
So in all sequences, usually
Yes,
the images looks like similar to CSF, like T1, T2, and other sequences also. Okay. So in our case, usually the T2 and pair images are not like similar to signal changes of CSF. Next.
This is one more MRI of the Alexander disease, where we can see periventricular rim with involvement of basal ganglia. One more possibility was viral encephalitis, par echo and rotaviral encephalitis, where we can see symmetrical white matter involvement and sometimes asymmetric also, but there will be associated diffusion restriction in the corpus callosum, and the age of onset will be usually in the neonatal period. This was one more differential based on MRI wave.
This happens only in neonates or older children also? Parico and rotaviral, this pattern of MRI involvement. Have you seen in older children?
No, sir, I have not seen, sir. We are seen in neonates, like 2 month, 3 month age infants.
It be like ALERD, acute leukoencephalopathy with restricted diffusion, your case?
ALERD.
ALERD, yes, sir.
Possible or not possible?
Clinically, the biphasic phase severe.
How do they present clinically mainly?
Clinically, they present with severe encephalopathy with seizures.
Seizures will be very prominent.
Yes, sir. And biphasic illness.
Imaging wise?
Imaging wise, there will be diffusion restriction across all the white matter. So, like.
Now, what are the findings in this child? Why it is not ALERD?
Only frontal bilateral symmetrical white matter was involved, like other posterior white matter was not involved, similar to
what
that of the corpus callosum was not having a diffusion restriction in our case.
The signal changes are seen in other sequences also in this child. Okay, next.
And continuing with the other investigations which we have done during the evaluation, we got during the first admission only 2D echo was done. No, not during the first admission. So when the child presented with deterioration, 2D echo was done, which showed asymmetrical septal hypertrophy with mildly reduced systolic dysfunction. The child has hypertrophic cardiomyopathy with LV dysfunction, which is usually seen in metabolic disorders. So to continue the evaluation, we have kept the possibilities of metabolic disorder. We have done muscle biopsy, which showed in histopathological examination, HND staining, it showed type 2 hypertrophy, diffuse type 2 hypertrophy, and advised mitochondrial complex assay. So we got complex assay analysis also done, in which the complex 1 level was 0.02. The control was 7.02. So the respiratory chain activity of the complex 1 was less than 30%. However, other complex 2, 3, 4 enzyme activity was maintained. And we got whole exome sequencing genetic analysis to confirm the diagnosis, which showed NDFS8 gene mutation in homozygous autosomal recessive gene mutation in mitochondrial complex 1 deficiency nuclear type 2, the disorder. And
I will interpret other variant they are reported.
Sir, leukodystrophy with hypomyelination, they'll present with features of ataxia and developmental delay, and there won't be any episodes of encephalopathy with the regressions. So that was not fitting into the phenotype of our case. So we considered even in case of uncertain significance, the phenotype of our case was fitting. So we sent Sanger sequencing to confirm, and the Sanger sequencing was only done for INDU-FS gene only, which showed heterozygous variant status in both the parents with homozygous status in the baby with for same mutation. So our final diagnosis after history, examination, and etiological evaluation, our case was a case of mild global developmental delay with quadriparesis, right more than left, with recurrent encephalopathy, with regression of milestones following episodes.
The age and sex of the baby at every point. I mean, in summary of history, examination, and diagnosis. It should be.
Yes, sir. 1 year female, case of mild global developmental delay with quadriparesis, right more than left, with recurrent encephalopathy, with regression of milestones following episodes of febrile illness, with frontal predominant leukodystrophy, with hypertrophic cardiomyopathy, with cardiac failure also. Secondary to primary mitochondrial disorder, complex 1 deficiency, nuclear type 2, NDUFS8 mutation, nuclear gene mutation, sir. Mitochondrial nuclear gene mutation. That's all, sir.
So to summarize that this child is present with recurrent episodes of encephalopathy before the weakness and encephalopathy. In this admission child, if you ask in detail, they will give 2 history episodes of encephalopathy like 4 months of age and also at, with the episode of chickenpox also. So this history is very important to consider metabolic causes and etiology when they present with a stroke or stroke-like episodes. So, and other things to consider like metabolic conditions are in this child, there is a recurrent episode and also it is more of a stroke-like, not like a stroke clinically, because encephalopathy was more compared to weakness and it is not splitting to vascular territory. And during follow-up, child developed cardiac problem also. So these are all in favor of metabolic condition rather than complication of chickenpox or vasculopathy. So, Gurpreet, should we discuss or you can go for question and answer?
Some slides on mitochondrial complex deficiency, primary mitochondrial disorders.
Now, somebody is asking, it is a mitochondrial disorder and it is an homozygous state in autosomal recessive inheritance. What is your comments?
It is a nuclear DNA mutation, sir. So it presents in autosomal recessive. Yes.
So even though it is a mitochondrial disorder, inheritance is nuclear mode. So that is the reason in the homozygous stage. In children, most commonly it is the nuclear. Mitochondrial disorder. So somebody is asking, will you go for genetic counseling for next baby in this specific child? Variant in
possibility, yes, sir. Since both the parents are heterozygotes, so the chances of next generation being affected is 50%. 50%.
No. How?
25.
Their question is, it is VAS. So yes, I will counsel. The genetic report is showing
VUS,
VA.
yes, sir. VUS.
How will you counsel?
So can we change this classification to pathogenic or likely pathogenic based on the studies?
Yeah.
Yes, sir. We can.
And what is the recurrence rate? Why it is 50%?
25. 25%.
Okay. So how will you counsel them for next baby?
Prenatal genetic analysis.
So already parents Sanger
sequencing is done. We'll look for similar mutation.
Go for amniocentesis or
amniocentesis.
Yeah.
So there are no questions. We can discuss the slides also.
Okay.
Yes, sir. I have done some slides on mitochondrial complex deficiency disorder, sir. Okay. In humans, the ATP production occurs by means of all these processes, which are oxidative phosphorylation, redox homeostasis, regulation of calcium, fatty acid oxidation, biogenesis of heme and iron sulfur protein, and programmed cell death, that is apoptosis. So I'm giving importance on oxidative phosphorylation because the complex deficiencies comes under this defect in oxidative phosphorylation. So the OXPHOS complex is located in the inner mitochondrial membrane, and it consists of, as we know, 5 main enzymatic complexes. The 5 enzymatic complexes are complex 1 to 4, and one more is 5th complex is called as ATP synthase which is the last in respiratory chain. Primary mitochondrial disorder is a term which is caused by pathogenic variants in the mitochondrial DNA. As we told, there will be both the mitochondrial as well as nuclear DNA, which may be defective. So it usually affects the pediatric central nervous system. This is a slide which shows this is the inner mitochondrial membrane where complexes are located. So in this slide, these are the subunits of the complexes, and the color coding is done to show the components of the complexes which are encoded by nuclear DNA, and one more coded by the mitochondrial DNA. In this, we can make out complex 2 is entirely coded by nuclear DNA, and it is more severe disorder. Nuclear DNA, the mitochondrial disorders with nuclear DNA mutation will be more severe compared to the mitochondrial mutations. So OXPHOS occurs within the 5 complexes of the respiratory chain, each of which has multiple protein subunits that must be properly assembled. 13 of these are coded by mitochondrial DNA, only 13, rest all are coded by nuclear DNAs. So in mitochondrial DNA, the subunits which are coded form components of 1, 3, 4, and 5. The 2 is entirely coded by nuclear DNA. Under the 2 only succinate dehydrogenase deficiency comes, which the MRI which I have shown. The remaining respiratory chain subunits in all the 5 complexes are encoded by nuclear DNA and imported into the mitochondria. So mitochondria has total 37 genes, out of which 13 are coded by nuclear DNA. So these are some of the DNA's complex with the corresponding genes which are being affected. Our child had this mutation NDFS8 in complex 1. Complex 2 usually less number of genes. It is usually coded by nuclear. Complex 3, complex 4, and complex 5. So coming to the specific discussion which we got from OMIM for our gene mutation, NDFS8 is a nuclear gene that encodes a core subunit of the mitochondrial complex 1, NDFS8, which facilitate the electron transfer. The common clinical features which are described in OMIM are developmental delay, epilepsy, extrapyramidal features, tone abnormalities, and the cardiomyopathy. Imaging abnormalities often involve white matter, basal ganglia, and brainstem. And biallelic pathogenic variant have severe presentation like leak syndrome and mitochondrial encephalopathy. Our child had homozygous mutation. So the first disorder was described like a leak syndrome with cardiomyopathy. These are some of the other features or some of the other details of this defects. Mitochondrial complex 1 deficiency, nuclear type 2. This was the defect in our child. Inheritance is autosomal recessive. In eyes, we can see nystagmus, hypertrophic cardiomyopathy, which was seen in our case. Respiratory insufficiency, child presented with respiratory arid breathing in failure in our case. And in CNS, global developmental delay was present, mild delay was noticed in our child, and white matter abnormalities was seen. And lactate was elevated in decompensated state, and mitochondrial complex 1 deficiency was seen in muscle, the biopsy which we have done. And the onset was early, as seen in our case, and the severity was more. Coming to some of the MRI imaging features which are seen in mitochondrial primary mitochondrial disorders, I'll be showing some of the images. So the spectrum of MRI imaging findings which are seen usually in the primary mitochondrial disorders includes basal ganglia signal intensity or changes, bar calcification, which we usually see in seen in leak syndromes, cortical signal intensity changes, and or malformations with subependymal cyst, and white matter changes like leukoencephalopathy with white matter cavitation seen in complex deficiencies, corpus callosal agenesis or dysgenesis, delayed myelination or hypomyelination, cerebral edema, usually cytotoxic. Our child also had the same picture of cytotoxic edema, and abnormal MR spectroscopy showing elevated lactate or succinate peak. These are the spectrum of MRI findings seen in mitochondrial disorders. This is a MRI image showing hyperintense signal in the basal ganglia involving caudate and potom and symmetrical involvement. Here we can see like calcification, which is usually seen in leaks like presentation. This is a common MRI will be seeing, and this is subcortical white matter changes with sparing of the periventricular region, which is seen usually in the Kearns-Sayre syndrome. And one more is periventricular white matter involvement with sparing of subcortical fibers with corpus callosal involvement in SDS deficiency. This is complex 2 deficiency. In previous one, periventricular white matter is spared. In this one, periventricular white matter is involved with sparing of subcortical arcade fibers, and corpus callosal involvement also is noticed. One more is pyruvate dehydrogenase deficiency, where we'll be knowing the child will be having MRI will be showing corpus callosal agenesis and small basal ganglia indistinct and subependymal cyst.
Very nice presentation, Arun, and interesting and informative for all of us. So if the child presents in OPD after the first admission, how would you treat? Is there anything we can do for this child regarding treatment is concerned? Any of those cocktail will help you?
Yes, sir. It would have helped, sir. Actually, complex 1 deficiency, they require a coenzyme Q supplementation, sir, because that is the factor which is required for complex 1 action. Coenzyme Q, we can start with thiamine, biotin, carnitine, and riboflavin was also.
Now, in this child, have you started, and what was the outcome in this child?
Sir, we have started in the second episode of deterioration, sir, but child didn't responded. Initially,
child has been started this mitochondrial cocktail following first admission only. Despite that, it is not second admission. Following first admission, it was started, but despite that, the child has deteriorated. Even though treatment is there, but most of them, the response is not so good. No, what is the outcome? Even if you start treatment,
yes, sir.
What is the outcome? Response rate.
Response.
If you start coenzyme Q, what is the outcome in this disease?
Poor only, sir, actually. Because it's a homozygous deletion involving nuclear gene, usually they won't respond.
Okay. So any other questions, queries from anybody, or we can conclude this session?
Yes.
I think, thank you, Dr. Raju and Dr. Arun, for very nice discussion and interesting presentation, Dr. Arun. And thank all the participants and our organizers. Thank you all, and good night.